Okay. Can you hear me now?
Yes, we can hear you, Obi.
Okay. Good morning, everyone. Good morning.
Good morning.
Okay. So I'm presenting for Nigeria on the database experience, and I'll be using the following outline for my presentation. Nigeria has a multi-site network of 25 centers. 22 of them were part of the Sickle 1, and we expanded to 2 more sites in the present. One of the sites was actually activated towards the end of the first phase, and so we're expanding to 2 more sites to complete 25 in this phase. That is Uyo and Yola. The expertise at the site, Professor Nash Oyekomi is the data coordinator of the site, of the network, and he's the director for the PI for H3 and Bionet in Nigeria, and he's also the director of the Center for Genomics Research and Innovation in Abuja. So we are working very, very closely with that center on issues of genomics and bioinformatics and on the Sickle work. The other expertise at the site are the director of the ITMS Center, Professor Obiageli, and knowing very well how important it is to integrate this registry with the hospital registries. In this phase, we have included the ICT support from the UATH by way of Jamilu Ahmad, and we have also included the network server support personnel in the university to be part of the network, and we have increased the data entry class portfolio, and we also have additional ICT support from the university. The infrastructure at the University of Abuja, we have been using the Red Cap, from inception, and this Red Cap is currently hosted on Amazon Web Services, and it has the following specifications. So we have the servers, we have the database server, and we also have a security. So these are the specifications for the Red Cap that we have. And in addition, we have the twin high-end Dell servers that were supplied from SADC with the following specifications. In addition to several desktop computers at this data center, CESA data center, as well as the hematology and pediatric clinics in the hospital. In the last phase, we purchased some mobile devices, which was sent to some of the high enrolling sites. And in this phase, we want to expand to make sure that all the sites have tablets, which they will use for recruitment, online patient recruitment. As far as the recruitment strategy is concerned, in the first phase, we aimed to recruit 6,000 patients, and at the end, we were able to recruit 6,453 patients into the registry from all the sites. And in this phase, we want to recruit additional 2,000 patients. This recruitment is actually going on from the network of clinical centers that have established adult and pediatric sickle cell clinics. And in addition to that, we have a newborn screening program, which is from the ASH Concert. And we also plan to have a newborn screening program from Sickle. And so we have we aim to have a birth cohort of 1,000 patients by screening 10,000 patients per year across the Sparkle sites in order to beef up the birth cohorts. We are planning the introduction of electronic data capture using tablets, and we are planning a training this month or early next month, because the year is almost ended, in order to, once we get all of the tablets from SADC, we want to implement the training that will help all the sites to go on to using mobile devices, to recruit patients in a timely manner. And this will also help us with data quality issues. For data quality, we developed and validated Excel spreadsheets for multi-site use in the first phase. And for the sites, the patients are enrolled and they are given unique identifiers at sites, and these identifiers help us to identify the origin of the patient, the sites that the patient has been recruited from. And the patients are sent from the sites in batches, to SESTA, where the data is checked, the quality is checked before they are uploaded by the data entry clerk. Once uploaded, the data manager carries out data validation using the REDCap data validation tool and raises queries to the data clerk where necessary. And the data clerk, if he notices anything in the Excel spreadsheets, so we actually use a uniform CRF, which was validated by all the site leads several times over several workshops. And this is the basis for the patient recruitment, along with the informed consent form, which patients use. So the data quality, the data clerk responds to the queries and seeks clarification from sites where such data was received. And upon that resolution of the queries, the data manager closes the queries. Other REDCap features such as missing variables, outliers, and so on are used to assess the quality of the data. For the backup system, we have data backup, which is ongoing. So there is detailed SOP. Following the SOP from SADC, we use it for this process, and it includes the regular backup of the data. For this purpose, we keep 3 sets of backups in 3 independent storage media. And then we also have other reliable storage devices. And so we perform week 1. There's a backup to device 1, week 2, backup in device 2, week 3, backup in device 3, and week 4, we back up, in that manner. In week 5, we back up in device 2, and so on and so forth. And this is repeated in this way. We haven't had any instance of disaster, but were that to happen, the latest backup copy will be used to update the system. What are the lessons learned? Our experiences show that REDCap is relatively easy to use for data collection, for cleaning, performing data quality checks, and for record tracking if after the clerk and the fellows have been trained on the use of REDCap. It's a friendly tool for a large data set. The data manager usually extracts simple summaries and reports on patient enrollment. And these are usually required for our meetings at the hub level to find out how we are doing with regards to our targets. And also this information is required at the working group presentations, at the consortium level. A simple but validated Excel spreadsheet showing all the data elements are presented in the CRF, which was designed, as I mentioned earlier, before use by the sites. And these Excel spreadsheets are returned regularly, and the data is cleaned before being uploaded into the database. So we are still using, at this moment, we are still using the CRS, which we produce centrally and ship to sites. And then when we wanted to do the follow-up, we also produced and shared across the sites. So we now have to go on to use of mobile devices in the second stage. And to ensure data safety, there's a regular backup of data on the C and on an external hard drive. And we've had the data management workshops that we've had, both online and on-site in Cape Town, were very useful in providing the skills needed for the work at the site. And also when we've had the site visits, we have brought in all the PIs from all the sites, and they have been able to, discuss and help, with making sure that if there are any challenges with any of the data elements on the CRF in a way that maybe they are ambiguous, these are resolved, and we are able to make sure that the instruments that we have are user-friendly. Since we started using the Red Cap at the University of Abuja, it was this project that introduced us to Red Cap, and the Red Cap was opened at the University of Abuja from Sparkle. And now the university has other active projects on this Red Cap database. We have the hypertension treatment in Nigeria. It's a very large epidemiological study. We also have the COVID seroprevalence study, and we also have the managing hypertension among people living with HIV and more. So as investigators are getting grants, they don't have to reinvent the wheel. These studies are hosted in the Red Cap on the university. The challenges that we have experienced or we anticipate may happen is that having established the database, we can see that this is achievable in our context. But however, integrating such into the electronic record systems of the Sparkle sites, because at the moment, a number of the hospitals are transiting to use of EMR. And that's why we actually brought some people on board from the hospital in this stage, so that we'll be able to integrate, the Sparkle registry into the EMR. Most of the hospitals that we're recruiting from are owned by the federal government. And so these federal government hospitals are using the same EMR. So once we want to be able to integrate into that system for sustainability beyond the project period. And similarly, patients on follow-up may not be consistent. So we anticipate that there might be some problem with this being able to integrate. And then we also anticipate that with the fact that most of the patients are fee paying and they only come to the hospital for routine clinic visits when they have the funds to do that. So if they are not able to do that, there might be some problem with the follow-up of patients, especially among the adults who feel that they know exactly what to do and they may not want to. So one of the ways that we are bridging that is with COVID, we started the use of social media. We started getting, we have the patient's contact details, and we would often batch their clinic attendance and reach out to them through WhatsApp messages. And we want to build that sustainability and patient engagement in order to make sure that we are working with the patient support groups and keeping the information and getting the patients mobilized and making it easy for them to access care. Another thing is that the electronic data collection, one of the challenges is the implementation of that. But having been part of SickleInAfrica, that we collected all the data using mobile, we are using tablets, we anticipate that the sites will be able to do this without a problem, but there has to be training before this is done across all the sites. Another thing we anticipate, in managing such a large network is the ease of communication. And so we have applied for a closed user group with MTN for all the clinical sites to enhance communication, to enhance data capture, to make our meetings seamless, and also for skills development activities. What have we done in terms of looking at utilizing the registry? As you are aware, we published the sickle cell disease clinical phenotypes in Nigeria, which was a preliminary analysis of the Sickle Pan-African Research Nigeria Consortium database. So we did this at about midway. And that actually helped us to know where to target, our skills development and further research activities, because we could see at that point that utilization of hydroxyurea was below 15%. And then we could see that the blood transfusion of patients with sickle cell disease was at about 63%. And so we are focusing on multidisciplinary training, on healthcare for patients, for healthcare workers using the SickleInAfrica standard of care guidelines. And so when we train the healthcare workers, and we also train the patients, we are anticipating that this will help us with improving the overall quality of care that is being provided. In like vein, we have a manuscript, the Sparkle Fellowships. Two of them worked on folate supplementation in sickle cell disease and its impact on degree of anemia, red cell indices, and frequency of transfusion, looking at the Sparkle Nigeria Registry. And then we also looked at malaria prophylaxis and its effectiveness in reducing transfusion needs and improving clinical outcomes in our cohorts. And these two Sparkle Fellowships have been completed, and they have the manuscripts have been developed and they have been submitted to Frontiers. There is an ongoing fellowship that is also looking at the relationship between hematological parameters and clinical disease severity in sickle cell disease, and this also is trained at the registry. Other fellowships are working on different things, not directly related, to the registry, but focused on Sparkle priority areas for research. These are some of the papers that were published in the first half of Sparkle, and these are the key personnel and the site PIs from the consortium. The Sparkle Nigeria has highly experienced researchers, clinicians, and collaborators who will bring their expertise to the different working groups and for the planned research studies in the second part. So I want to thank everyone for listening, and we'll be ready to take your questions. Thank you very much.